A very good morning to all, and it is a great pleasure to be once again at Varanasi, though I regret not being able to present personally because of genuine reason. So here I am, seek blessings of Lord Vishwanath and mentors and teachers for my FOGSI presidential candidature. And it is a great pleasure to be always being together with great leaders in the religious city of Baba Vishwanath ji. So I bring greetings from Lord Buddha's place, and this is the place of Sadhana Banaras also, that we can never obtain peace in the outer world until we make peace with ourselves. So torch, what is torch? It is a light which is sometimes getting scattered and sometimes it is dim and sometimes we overuse it. In next 20 minutes, I will like to present a few clear messages that how to deal with the all parts component of the torch. As we know, torch is a non-exhaustive acronym which is used to refer to main pathogens. This include Toxoplasmosis, Rubella, Cytomegalovirus, and Herpes simplex. And the O stands for other, which constitutes Syphilis, Hepatitis B, Parvovirus, and Varicella zoster. However, in today's talk, I will more concentrate on the Toxoplasma, Rubella, Cytomegalovirus, and Herpes simplex virus. So, when it is needed, how to optimize the interpretation of immunological result and how to suspect the torch. This will be the crux of the optimizing use of the torch for our good obstetrical outcome. So, pregnancy is a different situation. It is a unique maternal fetal connection. So, fetus is protected from infection. However, fetus can get infection from the mother in utero, peripartum. The gestation or the age of the fetus at time of infection influences degree of severity, and the infection have their own causative agent. Every component of the torch is different. However, a few common conditions are which predispose to torch infection is a poor hygienic conditions, contaminated blood or body secretion, as well as the sexually transmitted infection. What is the altered immunological status in the pregnancy which have the Th2 bias effect? It is ability to rapidly eliminate certain intracellular pathogen during pregnancy is affected. So the pregnancy is a special situation. Torch infection might not be that adverse effect on the maternal health, but it have got a great impact on the obstetrical outcome. So maternal risk factors are the lapsed immunization, sexually transmitted infection, animal exposure during pregnancy. And again, I emphasize that at what time the fetus is exposed to maternal infection, that is very, very important. As we know, our country and the world is looking for prevention of stillbirth, and infection is associated with around 20 to 25% of stillbirth and all 5% of the fetal growth restricted baby, especially in developing countries. It can have the effect by the direct infection, placental dysfunction, maternal stillness, or by stimulating spontaneous preterm birth. CMV, Parvo, and the Zika virus are important cause of stillbirth, while Rubella, HSV, Toxoplasma can cause significant fetal and neonatal morbidity as well as the mortality. So, how is the magnitude of the torch infection? Approximately 2 to 3% of all congenital anomalies are attributed to perinatal infection. So this is very important. It is not always the genetic, it is not always the syndrome. The infection can cause the congenital anomalies, and the initial evidence of infection may be seen, you can detect in utero, sometime in newborn period, and sometime even 4 to 5 years after. And when you suspect torch infection, when you get the unexplained intrauterine growth retardation, unexplained anomalies, and multiple clinical imaging and laboratory abnormalities. So it is the beautiful FOGSI guidelines that we have to have the 4 steps in our clinical practice. Suspect torch infection in pregnancy in mother, like the infectious mononucleosis like disease, fever with rash. Diagnose torch infection in pregnant women. Time the infection in relation to gestational age and diagnose torch infection in fetus, and then offer the management plan. So Routine in screening for the torch is not required for the general obstetrical population. It is not required for the women with the recurrent pregnancy loss. However, they can cause the sporadic pregnancy loss. In others, yes, hepatitis B and the syphilis, which has been recommended by almost all professional bodies to be screened for the pregnant women, but that no professional body actually recommend universal screening for torch infection. However, few societies are considering that the rubella serology testing should be done in preconception or in the first visit so that we know what is the immunological status. So one message to everybody that whosoever is doing torch for RPL and torch for the routine screening, that is not recommended and that is not cost effective. When you suspect that the patient can have the any torch infection, when he has the fever, malaise, sometimes fever with the rashes, or the exposure of women to the woman with the person of such illness, and suddenly you find a different obstacle like profile like the IUGR, then you should suspect that the patient can be having the torch infection. On ultrasound finding, if you find intracranial calcification, calcificatic calcification, ventriculomegaly, high drops, hepatosplenomegaly, ascites, and echogenic bowel, and the IUGR, you consider that this woman can have the torch infection and fetus is affected. However, only maternal infection does not say that the fetus is infected or affected, and you have to confirm the fetal infection by the torch PCR on the amniotic fluid. What is the routine test what we do in clinical practice? That is the ELISA. And a second important point is that no one single test actually can say that what is the immune status of the woman and what was the duration of infection. It is the first sample at the time of illness and the second sample after 4 weeks, and that the rise in titer and the change in titer gives you the best idea that what is the course of the infection and how is the possibility of the fetal infection. So if IgG says that it is immunity, but you have to like do the next sample after 4 weeks. So if the IgG is fourfold rise, or you are feeling that the IgM, which was initially high, it is not present, then you have to go for the avidity test. So high avidity test means that it is an infection before 3 months, and low avidity means that infection within 3 months. However, this is very important gap in our healthcare system that even in institution, we are not having access to these simple avidity tests, which actually is a very, very important test to assess that at what level of gestational age fetus was exposed to that infection. So this is one important gap, and as a FOGSI like presidential candidate, I wish to have this crossing the bridging this gap in our healthcare system. Fetal infection, when you say IUGR, when you find all these ultrasound findings, and then you have to confirm that the fetal infection is there, then amniotic fluid PCR is the routine test what we do. Chordocentesis has its own issue, but in both ways, we can confirm that the fetus is infected or not. It is very important that the evidence of fetal infection does not necessarily mean fetal infection. Fetus may not have the structural anomalies in spite of getting infected. So there is always a dilemma, and we can never predict for the surety what will be the long-term fetal secure. So whenever you have the findings of fetal infection, actually you have to be very guarded and the professional in your counseling that actually we cannot say that what will be the long-term fetal sequelae. Now coming to one by one, Toxoplasma gondii intracellular protozoa parasite, which is transmitted through the animal, pet. Cats are the important source or the inadequately cooked meal. And what is the toxoplasmosis? Again, the severity of the fetal toxoplasmosis again depend on the gestational age. From 13 week, it is around 15% affection to 36 week of the gestation, it is around 71% of the affection. What are the signs? It may be totally asymptomatic, it may be totally flu-like symptom, fever, headache, myalgia, and importantly, the most infected newborn may be born totally asymptomatic and suddenly they present as a low birth weight or hepatosplenomegaly, jaundice, and anemia. and sometimes the intracranial calcification and microcephaly. What are the professional body recommendation? It is again, screening is not recommended for all, and we have to understand the immunology, because all our clinical judgment depend upon the immunological interpretation. So IgG is if the IgG is positive, patient was immune. IgG appear up 2 to 3 weeks after infection and usually persists for lifetime in the eye titer. And IgM antibody appears 10 days after infection and usually become negative within 3 to 4 months. So IgM antibodies alone cannot be used to diagnose acute toxoplasmosis. And again, we have to switch to the avidity test. So the IgG is our mainstay, and if it is a high avidity IgG, we can say that infection was fast and the fetus has got the less chance of getting infected. So this is the interpretation that negative, no infection, negative equivocal, possibly acute infection, we can have false positive IgM. And again, the paired sample, I will emphasize that in all infection, the first sample and the 4 week, what is the change in IgG and IgM titer, along with the avidity test, gives you the fair idea that what should be done, how are the chances for the fetal infection. We have to confirm it is a it is a low avidity IgG, it is a 4-fold rise of IgG antibody in 4 weeks. Then we have to confirm that fetus is affected or not. And this is the amniotic PCR, which shows that the fetus is infected or not. And sensitivity of PCR also varies with gestational age and lowest before 18 weeks. So for all torch infection, actually fetal infection, you cannot do the good result with the amniocentesis before 18 to 20 weeks. And secondly, we have to do the amniocentesis after 4 weeks. Only then the results will give you certain information about it. How to treat toxoplasmosis? So 2 things I want to clear. There is 2 difference. When there is a maternal infection and no fetal infection, we give oral spiramycin 1 gram 8 daily because we want to prevent the vertical transmission. But if the fetus is infected, like toxoplasmosis PCR is positive, then the drug of choice is pyrimethamine and the sulfadiazine. Dosage are here 50 milligram BD pyrimethamine for 48 hours, followed by 50 milligram OD, and sulfadiazine 75 milligram per kg per day for 48 hours, or followed by 50 milligram kg every 12 hours with folinic acid rescue. Antenatal administration of this multi-drug regime, that is the pyrimethamine sulfadiazine, is not recommended in first trimester because of the multiple drugs, and these drugs you have to add with the folinic acid also. Spiramycin is not useful for the fetal treatment as it does not cross the placental barrier. How we can prevent? Careful, like public education about hand washing, handling cat litter, and the good food practice. Rubella is something which is a proven teratogen, and when it is exposed to the first trimester, it can cause the congenital rubella syndrome. Again, the illness is very, very mild. It is febrile illness, may or may be without rashes, and up to half of maternal infection, there can be subclinical despite viremia that may cause devastating fetal infection. So when there is sometimes epidemics in that particular community about the rubella, then all women who are pregnant in the first trimester, they get they have the risk for the rubella congenital syndrome. The diagnosis, the clinical history, again, it is a serological testing and the basic remain the same. And a high avidity IgG antibody indicate an infection at least 2 months in past. So in first trimester, it is the most teratogen. And again, the interpretation of the immunological test is so very important. And I have given the clear message that how to interpret the immunological test. So it can cause a congenital rubella syndrome, multiple congenital anomalies like heart cardiac anomalies, microcephaly, cataract, microophthalmia, hepatosplenomegaly. Important thing is that newborn is born with congenital rubella, they may shed virus for many months and thus be threat to other infant and the susceptible individual. There is no treatment for the rubella infection in the first trimester. If you are having multiple anomalies, you are seeing on ultrasound, termination is a good choice. and it is only prevention, that is the rubella vaccine. It should be given preconceptionally, avoid pregnancy at least for 1 to 3 months. However, the theoretical risk of anomalies after vaccination is only 2.6%, and this is very, very important that all girls should have the rubella vaccination, and in preconception or in first visit, there is a possibility that we check for the rubella status in our mother, what is the immunity status. CMV virus is the DNA virus of herpes family, and it can cause a lot of issue in the fetus, especially the hearing loss and the sensorineural and the cognitive dysfunction. So virus is secreted into all body fluids. So it is saliva, urine. So women who are caring for the children, who are working in the daycare centers, are like they are the vulnerable to get the CMV infection, and it is like herpes that it becomes latent with periodic reactivation, which is again characterized by viral shedding. It is important that patient can have the IgG antibodies, but it does not prevent the maternal recurrence reactivation or the reinfection. Diagnosis of non-primary CMV infection is challenged. Important thing is the primary infection rate are more crucial, and they can have an adverse effect in the fetus. In the non-primary infection, the fetal infection and affection is not that very high. So it is again trimester wise, and the naturally acquired immunity during pregnancy result in 70% risk reduction of the congenital CMV infection in future pregnancies. So the non-primary infection is not that dangerous, but the primary infection can cause a lot of issue into the fetus. Congenital CMV infection is a syndrome, and again the presentation of all torch infection is almost same. It is IUGR, calcification, chorioretinitis, cataract, and the most infected, in fact, again can be asymptomatic, but they are suddenly diagnosed after 6 months or 1 year, that the parents say that the child is not hearing, or the delayed milestones. So how to test for the CMV screening? So again, routine prenatal CMV screening is not recommended, but if you have the ultrasound picture or like the clinical scenario, as well as the high risk lifestyle modification, high risk lifestyle is like the woman caring for the babies, then we should suspect the CMV. And again, it is a IgG, IgM, and the paired sample at the 4 weeks apart. When there is a high anti-CMV IgG avidity, it indicates primary maternal infection more than 6 months before testing, so you are a little safe. But it is low avidity, then the fetus might be infected. So these are the ultrasound findings, and now a lot of work has been done for the neurosonogram and the MRI, and when you can have in two situations, like routine prenatal evaluation, or when you are suspecting that CMV infection is there, and the neurosonogram and the MRI of the fetus, there we can find the microcephaly, cerebral calcification, hydrox, and oligohydramnios. So MRI is a upcoming modality which tells a lot about the baby, the future neurocognitive function, but still it is generally accepted that negative MRI finding concomitant with the negative ultrasound result, if everything is fine, then you can say that this baby is cognitive and then sensoromotor development will be okay. So how to confirm the fetal infection? Like it is, we have the imaging, we have the MRI, but we have to confirm that the fetus is infected or not. So for this, nucleic acid amplification testing and the PCR of the cord blood, and you can take the like amniotic fluid PCR for the CMV. Important thing, a word of caution about chordosynthesis, that it is a potentially problem, procedure related problem, because it is a little bit complicated, and all professional body prefer that we do the amniotic fluid testing either for the PCR or for the nucleic acid amplification testing. No treatment is available till now, but now we have a good papers that the oral treatment with the valacyclovir and the IV treatment of the valganciclovir in the neonate. So these two drugs has been studied for the avoiding the adverse outcome of the CMV on the affected fetus in the future. Like in 4 or 5 years, we might be coming with a good drug. Hyperimmunoglobulin are also being studied with a passive immunization. It may lower the risk of congenital CMV infection when given to women with the primary disease. we don't have any CMV vaccine. So again, good hygiene, hand washing, and thankfully COVID has given one thing good besides being like on the virtual media, that we are sensitive to hand washing and our hygienic practices. Herpes is the last for the torch, that it is a sexually common, sexually transmitted infection, DNA virus, and we have two HSV1, HSV2. So HSV1 is the non-genital infection, and a good magnitude of adolescent and young women are infected with it. Type 2 HSV is almost sexually transmitted infection. So we can have the three categories. Just to recap that how we diagnose, how we suspect HSV. The first episode, when there is a incubation period, 6 to 8 days exposure, popular eruption with itching, followed by multiple vulvar and perineal lesion, which may not coalesce and then ulcerate. And sometimes there is no typical lesion, but only the uritis or the knife cut, like feeling on the patient vulva and vagina. Sometimes the severe features like lymphadenopathy, or after 2 weeks, all signs and symptoms disappear. So it comes and go, it comes and go. So instead of classic symptoms, so we have a classical clinical picture, but many times patient comes in with a non-classical picture. So the woman can have the asymptomatic primary HSV2 genital infection, and it can be very, very high incidence. So the first episode, the non-primary infection is most dangerous. Recurrent disease can be milder, though they can be having shading of the viral, but the most infected women shed virus intermittently over the time, and most HSV transmission occur during these periods of asymptomatic viral shedding. So on the couple counseling and the safe sexual practice, when we get the result, it is not only about treating, but it is all about the counseling also. How the virus herpes pass to fetus and neonate? The most important is peripartum, postnatal 10%, and intrauterine 5%. However, it is not considered an important cause of abortion, and the peripartum infection is the most important. And when you see that there is in the fetus, how it can affect, you can see skin blisters, CNS hydroencephaly, eyes, again microphthalmia, and the bone and viscera can be involved. So when you see the ultrasound suggestive of infection, we have to consider all the torch etiology. And however, the HSV, the labor room protocols and the obstetrical protocols play a very, very important role. So if it is an active lesion, then the cesarean section is like recommended by FOGSI as well as the ACOG. And it is important that, like again, of the two PCR, you can, how you diagnose, you can have the viral culture of the sample and you can have the PCR. So nowadays, because culture takes 7 to 10 days, but the PCR is very sensitive, the specimen handling is easy, and results are available in 1 to 2 days. So when patient comes to you in emergency, the PCR is the, or in the late gestational age, PCR is a better and the more sensitive test for the diagnosis of HSV. So the viral culture is one thing, and again immunological interpretation, same way as in the other torch infection, and the sensitivity and specificity is quite good about it. So ultrasound, again, on these features, IUGR calcification, non-immune fetal hydrops, severe ventriculomegaly, hydrancephaly, and skin scarring you can see. For recurrent HSV infection during pregnancy, antiviral treatment is given for the symptomatic relief. So this is important that if we want to prevent the peripartum transmission, then the acyclovir around 36 weeks to the postnatal period is a very good option, management option, which prevent the peripartum transmission of HSV, which is around 85%. So in active lesion, the cesarean delivery, acyclovir or valacyclovir suppression initiated at 36 weeks, and suppressive therapy also decrease viral shedding. And we actually don't know that not the current lesion, but the previous HSV infection, we should give valacyclovir or acyclovir or not. If the patient comes to you during delivery, always if there are a suspicious lesion, get it culture, get it PCR, And if the non-genital lesion, you can go for the vaginal delivery, but if a active genital lesion, go for the cesarean section. Babies should always be observed for 24 to 48 hours for the herpes blister. If there is a unexplained, like sometimes the baby needs a lumbar puncture for the anaphylaxis because of the disseminated HSV infection. And again, what is valacyclovir and acyclovir is a good choice. I will be one syphilis. Yes, VDRL by testing. We are doing all tests. When it is positive, it could be confirmed by the other test, that is the NAT or the other test. And the maternal syphilis is re-emerging in our world. We must know that many people are not getting that it is born out of the world, but actually in the world it is re-emerging. It can cause the fetal infection years after the infection. So we have a very, very simple treatment, that is benzathine penicillin and procaine penicillin. So syphilis remains with us. And the last, I will take just 1 or 2 minutes about the parvovirus, which is a fifth disease or erythema infectiosum. It can cause the fetal anemia. And the main mode of the transmission is respiratory or hand to mouth contact. So it is a simple, again, flu-like picture. It is a bright red rash which is giving you slapped cheek appearance, and then these all rash become lace-like and spread to trunk and extremity. Adults have milder rash and develop symptomatic polyarthralgia with recovery. IgM antibody is generated 7 to 10 days post-infection, and production persists for 3 to 4 months. Several days after IgM is produced, IgG antibody is detectable and persists for life with the natural immunity. So there can be vertical transmission, and it is one of the very, very important cause of fetal anemia and the non-immune hydrops. And the critical period for the fetal anemia is 13 to 16 weeks, which coincide with the period in which fetal hepatic hemoptysis is greatest. So it is causing fetal anemia by the immunological ways, and currently no data support evaluation of asymptomatic mother and stillborn for the parvovirus. Detection by the antibodies, then again the amniotic fluid PCR, but for the fetal anemia, middle cerebral artery Doppler PSV is very, very important tool to predict fetal anemia, and we have a good treatment about it. If the fetus is anemic, only 1 or 2 intrauterine transfusion are needed, because the 94% of these hydrops is resolved within 6 to 12 weeks, and overall mortality rate is less than 10%. So today, with the advances in fetal medicine, and SPART is all about it, that we have to create sensitivity about our all general obstetrician and gynecologists, that when you have this non-immune hydrops, fetal anemia, middle cerebral artery PSV is raised, then consider that it can be the parvovirus, and with the intrauterine transfusion, we can have a very, very good result. And after intrauterine transfusion, the abnormal neurodevelopment rate is yes, but in 32%, but rest all the other, it is around 68%, and we have the good result. No vaccine is available. Antiviral treatment is not preventing the maternal or fetal infection, and again, it is all about hygiene. So torch infection, we have to understand, they have not gone. In our country, especially in poor socioeconomic condition, rural people who are dealing with the animals, people who are having pets. So a lot of torch infection can cause the adverse obstetrical outcome, but it is not that it is the cause of the RPL. It is not the routine recommendation to screen for the torch, but when there is a clinical scenario, flu-like illness, ultrasound finding, then you have to consider torch with a good immunological interpretation, with a good fetal testing, with the help of fetal medicine specialists, and the right treatment and the right vaccine. Thank you for the patient hearing. I again regret that I am not with you in person due to genuine reason. And finally, the torch is complex, but we have the simple answers because we understand the root. Likewise, our professional body needs the simple, dedicated person, and I beg your wishes from the Lord Vishwanath, from mentors and teachers for my FOGSI presidential candidate. Your vote matters. There will be e-voting for FOGSI election from 1st August to 10 August. Be together and stay together. Thank you very much.